Right, let's make a start. Hi and good evening, everybody, NPA members and pharmacy colleagues. Look, thank you for joining us for what I hope and know will be another really interesting session in this virtual conference that the NPA have been running during the course of this week. The session title is Building Team Primary Care and How Can Independent Pharmacy Grow Collaboration and Integration with General Practice in the PCN Way of Working. So before I bring our panel colleagues in, just to declare, we have had a wee tiny bit of technical issues around our Zoom functionality tonight. I believe that you can enter stuff on Zoom, and if you have got the Zoom functionality up in front of you, please drop us a hello just so that we can see that it's working at your end as our audience. And I believe our panelists can also see Zoom and use Zoom. We will use the Zoom function for Q&A. So please type a wee message in, and hopefully we'll see. Hey, Mike O'Donnell, thank you, and good to see you, man. And also Kat, thank you. Right, great. Seems to be working for everybody, which is brilliant. Okay, that's the functionality bit. Okay, so tonight's session we'll cover off working for PC around PCNs between community pharmacy and general practice. And actually tonight we've got a really great panel, and lots of dear colleagues of mine have turned up for this one, which is super. We have left people on silent at the minute because it can be quite chaotic if everybody comes off mute. So please, if you can use chat as your means of communicating with us, that would be rather splendid. But don't be silent, use the chat function, and we will pick up your questions in the Q&A once we've been through our panelists. So let's get started, and firstly let me introduce my dear panel colleagues. Firstly, if I can introduce the eminent Graham Stretch, and Graham, if you share with us who you are and what you get up to, please.
So I think I've been asked this evening in a couple of capacities. So mainly because I'm the clinical director of a primary care network called Brentworth, which is a horribly shortened version of Brentford and Isleworth, which is in West London in Hounslow. We have 59,000 patients, 7 practices, and around about the same number of pharmacies, actually. So there's a certain synergy there, we hope. The other hat that I wear is the president of the PCPA, which is the Primary Care Pharmacy Association. So we try to represent pharmacists that work in primary care, which absolutely includes community, although obviously my colleagues at the NPA have a great deal more representation in that area. But we try to work with innovative community pharmacists to help them bring forward projects, particularly where they relate to working with colleagues perhaps in CCG, in GP, PCN. And we're very keen to include as many pharmacy technicians and pre-regs within our membership as possible. I'll let the other panelists introduce themselves before I go on at length for something that I am renowned for. But back to Michael for the next panelist.
Graham, beautiful. And for those that aren't familiar with the work of the PCPA, it is a truly excellent organisation. I'm a proud member myself, and it is one of the best valuable things I personally invest my money in. So check in, get on web, and see what you think too. Thanks, Graham. Secondly, my dear NPA board member colleague Sanjeev, please, for an intro.
Hi, yes, so Sanjeev Panisar, run a group of 5 independent community pharmacies in the Birmingham area. Been established since 1982, so been quite integrated within the community for coming up to nearly 40 years now, actually. So seen a real big change in the generations of that community. I also sit on Birmingham and Solihull Local Pharmaceutical Committee. So it's coming up to my 6th year for that now, and just joined the board of directors of the NPA this year as well. That's a little bit about myself.
Thank you, beautiful. Thanks, Sanjeev. Next, my sister-in-arms, Lovejeet Kandula.
Good evening, everyone. Thanks, Michael. My name is Lovejeet Kandula. I'm currently Director of Transformation and Acting Chief Officer of Greater Manchester LPC. I'm also here in another capacity today, well, 2 actually. One is that I lead on primary care network integration and PQS and anything related to collaborative working at the GMLPC, which actually represents over 600 pharmacies at this time. But also I represent and work with Graham Stretch at the PCPA as a community pharmacy integration lead. And the purpose of that really is to ensure that we can, as a team, share best practice with our clinical directors, other pharmacists in other settings, and develop very innovative ways of working so that we can replicate that across the country. And they do produce some absolutely fantastic resources and have some great Telegram discussion groups, some groups of which there are over 4,000 members, I think, now. So I'd really encourage you to at least join the Telegram group, which is free. And if you think it's valuable, then move on. And hopefully we can share a bit more about our progress a bit later on.
Beautifully plugged, and also have a look at what Graham's put on chat as well. Thank you, Lovejoy. Always good to see you, and thank you for supporting this dialogue. Next, a dear colleague of mine from the southwest, down in Devon and Cornwall, Neil Parsons.
Thanks, Michael. My name's Neil Parsons. I'm business manager at a GP practice in East Cornwall. I just really have a keen interest about collaborating with community pharmacy. I've been involved in quite a lot of quality improvement work with community pharmacy teams, trying to build up different working relationships, and just have a keen interest in about how do we work together more collaboratively, how do we make greater efficiencies and drive productivity across the prescribing and community pharmacy interface.
Beautiful, Neil. And Neil, the other year, was practice manager of the year for the National Association of Primary Care. So he is a true star. And lastly, but definitely not leastly, my dear NPA colleague Nick Kay.
Hi, Michael. Yeah, good evening, everyone. Thanks for having me on this call. So my name's Nick Kay. I'm a third generation pharmacist, so I should have known better, is the line I often start with. Currently, I am lucky enough to be the vice chair of the NPA, which is exceptionally exciting and also challenging at times. I used to own a really busy community pharmacy in Newquay doing 26,000 prescription items a month. I've since sold that and now have shares in two businesses in Hendras in Penryn, one doing about 14,000, one doing about 4,000. And also in another world, I'm also a partner in a GP practice, but that is in a different town to the community pharmacy. So it's really interesting to see things from both sides. So I'm really looking forward to see what today brings, and yeah.
Beautiful. Right, what a panel, what a set of experiences, yeah. Let's get stuck in. Ahead of just asking the panel to kind of spend a wee bit of time with us, I primed our panel to think in the following terms, but please, you're not obliged to follow my magic formula. I wanted you to kind of help us check in reality where you think the PCN journey is going and what it's doing in the context of how community pharmacy is working with general practice. I wanted you to maybe think a little bit about the risks that we need to overcome as we kind of take this route forward, because it ain't an easy route, is it? And I'd like you to maybe think a little bit about the rewards and the realization of stuff. You know, what are we going to get if we go on this journey together? GP, surgeries, community pharmacies within the PCN way of working. So that's the kind of the context of that, dear audience. So what I'll do now is, in the order in which I introduce them, we'll go back to Graham. Graham, we lost a wee bit of time at the start there, dear man, because of the technical stuff. So if I could give you a nudge after about 7 or 8 minutes or so, would that be okay?
Will come off mute, which would help.
Thank
that's
you.
fine. I think, you know, there's two separate things here. The intention of networks was to be exactly that, and that they were to bring together groups of organisations working in our communities to work more closely together. And the idea was they would allow space for practitioners who felt pushed. So principally it was sold to GPs on the basis that you're really busy, there is a shortage of GPs, we can't get GPs, we can't get nurses. So what we'll do instead is allow and help you to recruit other healthcare professionals to work together with all of the community providers. So obviously that includes community pharmacy, but also includes dietetics, includes physiotherapy and district nursing and all the other organisations that provide care for our patients. Bring those people together under a single organisation at a level that was big enough to be efficient, so 30 to 60,000, but not so big that it was impersonal, that it involved people from outside of the area. And at the same time, of course, the CCGs are starting to go up to more regional level organisations. So in other words, the NHS was moving in two directions, to be more regional, but also to be more local at the same time. The idea being that we might well be able to work more closely with partners who knew the community best. And so the reason why that was effective, we hoped, was that it would provide both of those things. So local accountability to patients, and also allow more space for practitioners to deliver their care. That was the idea. And it was supposed to be a network of equals. The problem, of course, is that the funding was largely seen to have come from the GP Global Sum and pump primed for provision of extra professionals within general practice. And so what has happened, of course, is that the various constraints upon PCNs mean that they're definitely not a commissioner. And that's a really, really important point that I'm not absolutely sure has got over properly. So we're not commissioning services. So I know that my local pharmacist could do a much better job of checking the blood pressure of my type 2 diabetics, for example, than GP. It's a really difficult task to get these kind of working age type 2 diabetics to come and get their blood pressure checked, but they will come into the pharmacy and collect their metformin or whatever it might be. And pharmacists, of course, are quite able to measure their blood pressure. But what I can't do as a clinical director is say, look, here's £20, I want you to check your blood pressures, and I want you to go online and put it into the records. Sensible as that would be, an obvious sensible use of resources and time for everybody involved. I can't do that. I can't commission via the funding from the desk. I can't commission services in that way. Instead, what's done, and this was largely to sell it to general practice, is we will provide you with funds to spend on workforce. So you have this thing called the ARRS, which those of you not familiar with, is the Additional Role Reimbursement Scheme, which for pharmacy provides around about £55,000 a year now. That's changed. Provision of which will be for a whole-time equivalent pharmacist. We can go down to half-time, so there is 50% is available to us, and that's a really important point. So there is potential, in fact, for job shares and for multi-sector working, portfolio working, call it what you will. So we can claim money for whole-time equivalent pharmacists, but even that comes with some strings attached. So those pharmacists will have to join the national training pathway provided by the CPPE, and there's an expectation that they will undergo training to be prescribers, both of which are funded separately from the £55,000. So it's quite a good deal, really, you would think. We can hire pharmacists to work across our practices. We'll be able to claim the money in order to be able to fund them. But this isn't my being able to hire a community pharmacy to do the job for the community. This is me getting a separate individual to do that. And so that's a barrier, if you like. Of course, pharmacy technicians are now included in the scheme. That also presents both benefits and risks to community pharmacies who might find they're losing their staff to PCNs. And again, the 50% figure applies to pharmacy technicians. And indeed, there's a kind of nominal cap of one technician per PCN to try and avoid too much pulling away of staff from both community and hospital sectors. So the PCNs are set up in order to provide extra workforce to deliver services in the networks. And in an ideal world, what would happen then is the PCNs would be very outward looking and look to partner with various organisations in order to be able to provide those services. And on that basis, be able to provide improved care for their communities. A key thing here is inequality and looking at variation, if you like, of outcomes for patients. So I get regular data about my community in Brentford and Isleworth, and I can see which particular wards have bad outcomes in terms of MMR immunisation, in terms of asthma, in terms of hospital admissions, smoking, drug misuse, and so on. And the idea is that we should be concentrating our efforts and concentrating these extra staff that we have to try and address some of those inequalities. The community pharmacists know only too well, actually, what the inequalities are, because it's them that sees these patients all the time. It's those colleagues that see the patients all the time. And so what we're having to do is try and think of ways that we can use the funding that's available to us in order to be able to work together with our colleagues. Now, that's me as a pharmacist trying my best, and the reason I took the job actually was to try and do precisely that, integrate with my pharmacist colleagues in the community. That was one of the main drivers for me putting my name forward. But it's not easy, and we're only just starting to work out ways that we can use the funding available to us to partner properly with community pharmacies in order to be able to deliver some of those services that we know that you could do very well. And the drive on immunisations right now, there's some fairly obvious solutions, but the transfer of funds is presenting us with a challenge, if we're honest. Now that I do have some solutions that I hope will work. We're at advertising, we're at interview stage for what we're hoping will be one solution, which is our network community pharmacist. I'm looking at Michael at the time. And the idea of this one is that we will provide our local community pharmacists who were invited via the LPCs to tender for essentially one of those whole-time equivalent positions, and we will hand over the £55,000 to the pharmacy, and they can then hire a pharmacist. Might be their existing pharmacist, maybe we'll use the 50% rule, and from the pharmacies, and we hope that will be a collaborative effort with all of the pharmacists within our network area, we'll provide services for patients residing in our PCN areas. And so the pharmacy will be the employer and will deliver the services as written in the DES. It can just as easily be done from a pharmacy as from the surgery. Indeed, the surgeries are very short of room space. So there is a real synergy here that the pharmacies are able to, they know the patient's fares, the patients can come in at times very often outside normal working hours, and provision can be made then for the services that you're probably aware of in the specifications that the PCNs have to deliver. So the DES, you'll hear people calling about the Directed Enhanced Scheme, the DES, lays out the specifications of what PCNs are required to deliver. And amongst other things, they're required to deliver this year a structured medication review for every patient who's on 10 or more items, who has a particular level of frailty measured by an electronic mechanism, who resides in a care home, who has one of 16 different high-risk medications, or who has a learning difficulty or similar. Now, you know those patients in the community, you know who's getting the methotrexate, who's getting the azathioprine, and you know who's particularly frail. You'll certainly know those that get more than 10 items. Very often they'll be given a compliance aid for that. And so why on earth do those patients, why on earth do they have to come into the surgery to have a medication review? We've got pharmacists spread across our network who know them best. And so it seems to me that was the driver. That's how I put it to the board of the PCN and sold, if you like, this idea that we should be engaging with the pharmacies. And if we don't do that, we just waste that resource. I've spent the last 2 weeks trying to recruit pharmacists, and we always said that in the first year we'll be fine. We'll be able to get pharmacists into our PCNs. Second year, we're going to run out of trained pharmacists. Third year, fourth year, fifth year, we're literally going to have to grow our own. And that's exactly what's happened. This latest round of recruitment, with the people simply aren't there at the senior level, and that's fine. But we do have community pharmacists who are willing and able, and very experienced often. They just need access to notes, so the IT, simple. I've got a laptop, I'm speaking on it now, full access to all of the surgeries that I'm involved with in the PCN. So that's an easy one, that can just be set up in the pharmacy. We also need to provide training for them. So those pharmacists will be able to access the pathway and train with the CPPU, and they'll also get funded and clinical supervision to undertake prescribing. So it seems to me this is a very sensible way forward. If I, as a PCN, can't recruit pharmacists, and yet I have 7 or more pharmacies with several pharmacists, some of them, on my patch, why not redirect that resource, training and financial, towards those pharmacies and grow reliable? Some of these pharmacists have been there for 20, 30 years. They're not going anywhere. They're not going to leave, as some of my pharmacists have. Why not build those resources in a much more sustainable way that we hope and expect will outlive what is actually a 5-year plan? And so moving forward, we hope to build sustainable partnerships in that way. What we will do is we'll get the appointment made, we'll get the contract signed off. They're with the lawyers at the moment, and then we'll absolutely share that as a business case, which I hope then the LPC leads for other PCNs can take as a compelling case to say this is a way, and there will be other ways, a way of bringing forward meaningful collaboration between community and solve some of your problems with recruitment, retention, both for you and for me, and bring the footfall in and improve my standing in the community as a place I can go to get real clinical interventions. And I'm a prescriber. So all of those calls that are coming from the community pharmacy, they're frustrated, they can't get past the receptionist. The doctors are frustrated because they're getting interrupted in their surgeries. Those will go away Because now what you've got is a pharmacist who can deal with those things in the pharmacies, working day to day, knows the pharmacy, knows the patients. So those calls would go away. So there's a win-win here. Win-win-win, actually, because it's better for patients, it's better for the community pharmacy, it's better for the PCN, I feel. I'm hoping there are other solutions, but after what's now a year, I'm unable to think of meaningful solutions that don't involve allowing the community pharmacy to take the lead in recruitment, delivery of service to patients that we share in the NPA share. We're all part of the same network. Thank you, Michael. I know I went off.
Graham, the model that you described there has already caught a lot of imagination. So thank you for what you're doing with that. Graham, I know we'll also come back to you for Q&A on the panel as well. Dear audience, don't be afraid to stick your name and a couple of questions or observations up there. So next I'd like to draw on my NPA colleague Sanjeev again, just to tell some stories about his experience of working across the interface with general practice in his practices across the Midlands, mate. So over to yourself, please.
Yeah, I've found the PCN model in itself as a concept is great. In my personal experience, I think the execution is where it's failed at the moment. When it first started and the engagement process began, when pharmacists started engaging with GPs, what we found was that there were lead GPs and PCNs that were unaware of pharmacists' involvement within a PCN, and they didn't even realise what pharmacies were doing within that network, as it were. I've even had pharmacists who actually work within the GP sector at the moment, and even they're unaware of actually the involvement. So I think that the communication has been lacking to really get this off the ground from the get-go. That's just my personal experience. I'm sure in other areas there's been a fantastic uptake and a real collaborative approach. So I think there needs to be a greater emphasis on the integration of the pharmacy network within the GP network if a PCN is going to operate successfully. That being said, like I said, if it's done correctly, I think it offers a fantastic opportunity to both healthcare professionals to make a real difference to improve the health outcomes for thousands of patients within the community. But that communication, that link, I don't think has been executed correctly at this stage. So I'm a real advocate for it, but it's got to be integrated fairly amongst both healthcare professionals. And I think if this pandemic has proved anything, it's the value that community pharmacy can bring to the table, and how vital the integration is with the community pharmacy sector within the system, and how we need it more now than ever. I think that the upcoming flu season is gonna prove that as well. That if we work collaboratively, those health outcomes can and targets can be achieved. But there's a lot of work, I think, to be done to structure it in a way so that it works effectively. So that's kind of my take on it at the moment. And I think that, again, the structure in terms of trying to bring pharmacists within the GP setting to provide a lot of those services can almost be a bit of an inefficient use of the system. There's community pharmacists that are there on the doorstep within a stone's throw away of GP settings. That it's almost like an open doors policy. Patients have got access without need of an appointment, and can access services almost immediately. And there's those community pharmacy professionals that are there ready to take on those services and to kind of throw the hat in really and really improve things.
Sanjeev, lovely, thank you. I mean, we have to face into the reality here. It is a mixed picture, isn't it? And there are some brilliant examples of innovation and integration going on, and there are some slower burns going on. But thank you for your thoughts there. Next, Lovejet, draw yourself in, please.
Okay, good evening, everybody. I thought what I'll do is I'll just start by talking about how Greater Manchester's LPC has approached the PCN challenge. And as everybody's articulated so far, it is a big challenge. But one of the biggest things for us is we've got 58 PCNs, and we needed to obviously meet the PQS, but we've got a big challenge on our hands as to how we're going to manage that, how we're going to coordinate the activity, how we're going to, and what's really fundamental to this process for us is building relationships within each locality. So that's the kind of role that we've taken. So to give you an example of what we've done, we were slightly different in our approach to the PQS, in which we used the Greater Manchester Health and Social Care Partnership to actually facilitate introductory emails between our community pharmacy PCN lead and each clinical director as step one. And step two, going on from that, is that the executive level actually set up something called a locality leaders network, where clinical directors and GP leads and various other colleagues from PCNs actually attend meetings with the partnership executive leads. And now we've actually got community pharmacy to also attend that meeting. And it's absolutely gone fantastically. I mean, we've had another revival of this post-COVID, and we had 30 out of our 58 PCN leads attend that and actually start to jointly work out opportunities for collaboration and capitalize on what's happened during COVID. So to give you an example, during COVID, we thought, well, we can see pockets of activity. It is variable because it really depends on the individual. It depends on the company policy, let's say, that we also need some more levers because we've got nothing in the national contract to help to move this forward. But what we decided is that we're going to keep the momentum going. So we set up, for example, a WhatsApp group between 58 PCN leads that is literally going till midnight every single day. And out of that, the CCG leads actually started to approach the LPC and asked for community pharmacists to be linked to them during the COVID response to provide intelligence, insight, to get a background to understand what the resilience picture is, how we could have access to testing, how we could basically provide further support for patients. And where it's worked absolutely fantastically. And I think what I will say is that we are at a foundation stage. So just before COVID, we'd spoken to the partnership to get funding to support PCN leadership training. It's very important that our community pharmacists are supported and trained to be able to interact to the level that we want them to. We can't just expect that somebody's going to do a good a job as Mr. Lennox on our panel or as Graham, because they've not got the experience of actually having that conversation with the commissioner, identifying opportunities. And we've set the structure up in a way that we're behind them to say, when you do have that conversation, come to us, and then we will help you develop that. So post-COVID and post the locality leaders network, post some bits of local collaboration that we've had on stop smoking already, which has been very positive, we've actually utilised the flu vaccination planning. So I have actually got 10 localities within Greater Manchester, and with each locality we've had at least 2 PCN community pharmacy leads attend the meeting with our GP colleague clinical directors and and CCGs and everybody else relating from the screens and immunisation and vaccination team. And out of those discussions, which have been received extremely positively by the networks, they're really impressed with the level of engagement and collaboration we've got, we possibly will have a joint appointment system set up for flu in one of the PCN areas, IT enabled, because I think from where I'm sitting, patient access to vaccinations is really important. We know it's going to be a challenge. We know the demand is going to be high. And what we've decided is that we need to leverage the GP practices. And I've been told that there could be an 8,000 vaccination shortfall in terms of the capacity for GP practice to deliver in that area, which is huge. And what they're asking for is for community pharmacy to be able to step in and actually support them. And when community pharmacy are struggling, that we ask our GP practice colleagues. And the LMC have also been very, very supportive of this approach. When I have more information about this, I will let you know. But it's also been received really well from the national team. And in terms of the way forward, we are continuing to set our foundation structure. But I absolutely recognise the comments that my other colleagues have made, is that there are PCN clinical directors talk to us. They want to know what we can do, but they're extremely challenged in terms of being able to transfer the finance or make financial arrangements with us so we can actually deliver something. And the second key problem that we have is, despite the NHS long-term plan telling us that integration is the way forward and PCN's the way forward, community pharmacy at this time do not have any national levers to be able to capitalise on that. So we've got goodwill and we've got very enthusiastic pharmacists who really want to make a difference. They are contributing and doing that delivery. But where basically there are some areas that are saying, well, there's nothing in the national contract, so I'm not sure what the direction is, I'm not sure. So for the meantime, we are working with NHS England Improvement to set a direction and hopefully maybe follow Graham's model of trying to do a shared recruitment approach, which is certainly something that's also been discussed in Manchester, but not progressed as much as what Graham's area has done. So I think the challenge for us is we do need some clarity on what the direction is, for community pharmacy working with general practice at all. And that's the challenge I've got, because I don't want to just see one PCN out of 58 working. What I want to see is all 58 PCNs doing something in collaboration, but leveraging each other's strengths, making use of effective resources, and ultimately supporting our local health populations. So stage 4 for us is going to be about gaining some workforce development funding that we want to use to develop our community pharmacy leaders a bit further. And that will be an opportunity for them to be empowered to be able to start scoping opportunities with the PCNs. But the PCN clinical directors have come back to us and said, we are keen to work with community pharmacy, but our resource is very, very limited. And I don't think we've been commissioned in a way, rightly so, as Graham said, we can't commission you to do anything. And that's a real challenge. So what we're trying to do is find other ways using IT technology, sharing information, being on a platform for access to GM shared cared records, to put the enablers in place so that we can actually move forward and start to support general practice very, very effectively. I think that's it from me for now. Thank you.
Wow. So what I picked up from that, well, really inspiring stuff. I really love you were talking about the levers and leveraging your own system, and I think Manchester has played that really strongly. Loving the idea of the flu there and the joint appointment system that you're piloting. I know we're in the right review at the minute, and that's an area that interests me mightily as well, but it just shows you the power of an LPC to get behind stuff and to actually be that agent of change. Thank you, Lovejoy. So next my colleague from the deep southwest, Neil Parsons, to talk about his practical delivery of stuff at the interface in his world. Thanks, Neil.
Thanks, Michael. I'd echo what the other panelists have said, so I'm not going to go over that in any detail. I guess one of the interesting things that I'm going to talk about is perhaps a more practical approach that we've been taking down in Cornwall, where we've been doing some test and learn pilots around thinking about how do we get community pharmacy teams and practice teams around prescribing processes, think about how they could better collaborate. And I think it's worth just reflecting that there are already services that exist where we can collaborate now and we don't need to commission. New medicine service and reviews and support. Certainly it's an area that we've been working on with our community pharmacy and thinking about how do we move some of the workload that our practice nurse teams take on in terms of new medicine initiation, and thinking about how do they work in a more joined up way with community pharmacy, given that patients will be in and out collecting medicine. Pharmacists there. So we've been doing some quality improvement, thinking about how you bring those teams together, and actually you do some really basic stuff. And I've been so surprised that actually teams working in general practice dealing with prescriptions often know individuals but have never met them, and we've been doing some really interesting stuff about just spending time pre-COVID bringing people together and actually just introducing themselves, talking about what they do. We've been looking at some of those process flows that go on and trying to establish where interventions from community pharmacy could help, doing big pieces around just basically talking. I think we heard about WhatsApp groups. In our health community, we have a Telegram group where they talk about how they're managing day-to-day kind of out of stock issues, and again just trying to have more dialogue. We've been doing bits of work about considering the impact of ERD and how that could help. We've had some great success with community pharmacies identifying suitable patients for ERD and then getting those conversions to happen to try and make that more seamless. So I think for us it's felt like there's been some practical threads of opportunity that we could use some quality improvement to bring people together, to build relationships, get them talking and working on some joint projects where they can really think about how we improve and communicate, and doing some simple things as well about even communicating about how long it takes to get a prescription. And it's been quite surprising how we use different languages about we'll have it. You can have we'll get your meds to you within 2 working or 2 days or whatever it might be. And actually then community pharmacy saying, well, hang on a minute, it's going to take us a bit of time to dispense and get that sorted out. So it's been great about joining up some of those messages to patients and talking about actually it takes 4 days now to get you your medicine by the time it goes through the process, to reduce some of those processes going on. So I think there are some real practical things we could do around improving relationships and communication locally and how we process work. I think there's loads of stuff happening around prescription fails where we could do things. I was really intrigued to hear Graham talk about the use of blood pressure monitoring, and I completely agree with you. You could move that well away from general practice. Lighted in to support that, and again, how you commission that, you're right, it remains a challenge in how you get that to happen. New medicine services have loads of potential and actually could drive some real quality, because I think there are real opportunities with some of those long-term condition patients to think about how we could join those up together, how we can ask for those new med reviews to happen. And again, even expanded into medical discharges from hospital. Great frustration about how some of the policies align, but I think I think we could really try and influence and improve some of those opportunities. I think collaborative flu is another big area. It does feel like there are real opportunities to work together. It feels this year there's a real opportunity to access patients to get the flus done. But I think there's a greater challenge around how do we socially distance through COVID. If they're not synergies and opportunities and problems we share together, and certainly in our local health community, we're talking about actually doing them together to try and just get it done and have joined up messages and work together collaboratively to make sure we vaccinate as many patients as we possibly can. So I think there are some really interesting opportunities. I think I'd echo Graham's comments about workforce. I think I can only speak locally. I don't know the national picture, but I think we're missing a trick. And there are definitely opportunities where we could do that across the system rather than just being within individual practice. And I think my experience working in general practice, and again, this isn't a generalisation, it's about my local experience in my practice, is I still think we have lots of prescription process failures that are taking place that we could actually spot most of them coming up, but we let them happen and then we spend lots of time sorting them out. It creates issues about communicating with one another, frustrations for patients, community pharmacies, for ourselves. I think we could work more collaboratively in about smoothing out those processes, aligning meds, authorization in a much more joined up way, getting blood pressures done so they don't become a problem when we want to reauthorize and reissue. So I think there are practical things that we could be getting hold of. I think communication relationships are really important. Identifying shared areas of working around ERD, around new med service can be very practical and helpful. And probably some kind of, we're finding that we're having to work a lot at communicating and engaging. That takes time. We're all hard pressed, we're knackered, and actually trying to create a culture and an environment and climate where we could do that, I think is also going to be beneficial, but that takes time, energy, it takes people. I think we could do more to work on that to make those improvements. I'm probably not going to say much more, and I'm going to hand back to Michael.
Neil, beautiful, thank you. And as somebody that lives and has done various roles around the system in the Southwest, I've witnessed the practical work that Neil has been involved in, and some of the figures from it are quite remarkable. Like at one stage, one of the practices Neil's alluding to had the fastest growth rate of ERD in the entire country, and that's because the practices were working hand in glove around the processes of it with the community pharmacies. So Neil, thank you. A big takeaway from there really was that quality improvement statement and how actually we can do stuff right now. We don't need novel, we don't need to innovate, we just need to optimize what's already at the interface and do that around processes and get the people together as well. Thanks, Neil, really strong. Nick, you have the honor of being our final panel speaker before we go into discussion mode, please.
Excellent. I mean, how do you follow those guys? That was absolutely amazing. So I think for me, what I'd like to do is talk from a Cornwall perspective and from the way in which we've experienced it from our community pharmacy point of view. At the start of the programme, I did say that I was a partner in a GP practice, but really importantly, the community pharmacy that I part own is in a completely different town to where I am a partner in a GP practice. So actually all the challenges which I've heard from Sanjeev and the other community pharmacists around communications and all those other things are absolutely live to us. I think in Cornwall we did a really good job because we identified our primary care network leads from community pharmacy. We put them all through leadership training, and then we did a meet and greet. We did the leadership training in the same room as the clinical directors were all going to be, and we did speed dating with them. They all had 5 minutes to chat to each other. It was well organised by my colleague Philip Yelling down in Cornwall LPC, and it was really well done. And I think that is really important. In the primary care network that my community pharmacy sits, I'm really keen in getting innovation of young talent and progressing people through this experience. So our primary care network lead is actually a guy called Oliver Williams, who's 24, but he is absolutely fantastic and has absolutely grabbed the role with both hands. So, some of the examples of the things that he's been doing and speaking to his clinical director, who's a GP, in a GP practice, not where the pharmacy is attached, in again another GP practice. So the lines of communication are more challenging, but he's made them work. He's been talking about ERD, as Neil said, which has worked really well, and starting to roll that out from a practice with a starting point of 0. He's also been talking about how they would hold different palliative care drugs. Although we have a specialist system, this is keen for one of our clinical directors, especially under the COVID. He's also been talking about how we would optimize B12 injections, just some practical things about what he's been doing. He's also been organising nutritional training, so how they optimise the nutrition training within that primary care network. And as well, when he was involved with things like blister packs and pushback around blister packs, and actually our clinical director became our system advocate. And I think that was really important and showed collaborative working in that way, that the system advocate, your community pharmacy advocate, actually becomes your GP clinical director, which I think is actually really, really, really interesting, and shows how a primary care network can work really well. Other examples of good practice, we now have some of our GP pharmacists actually holding regular meetings virtually with our primary care network community pharmacist nominees. And I think one of the other speakers was talking, I think Ludwig was talking about the difference between, and the understanding, and Sanjeev was talking about the understanding of the system between a primary care network pharmacist under the extended roles that Graham was talking about, compared to the community pharmacist nominated PCN lead. And I think the system is struggling sometimes to understand those differences in people. In Cornwall, our workforce is absolutely acutely problematic. We have huge issues with the recruitment of all sectors, pharmacists included. We have portfolio pharmacists that work across GP and community, and also primary care network and community pharmacy. But I absolutely love Graham's model, and I'm going to be talking to him about this straight after this, because I think that is absolutely novel and fantastic. So for me, I think it has been varied as well. There has been very little engagement in some areas, but I think where it's done well, it does do really well. Our main challenging, when we talk about, we're getting invites to go to meetings in community pharmacy, come to our clinical directors meeting, come and engage in our wide primary care network. Slightly easier in a virtual world, but I've got some practical things to think about in the community pharmacy. How am I going to attend? How am I going to get backfill? How am I going to get upskilled? How am I going to get training? For me, there's some questions around how pharmacy integration funding could actually be used to integrate absolutely properly and correctly within primary care networks. And I think this is an opportunity, and the comment in the chat box I think is a fair one about the engagement of community pharmacists, and I think some of that comes because of the lack of the national direction about where our place sits within that. And I think this forum of sharing best practice and great practice will be a way in which we can shout about how it works and how it works really well. I'm conscious I'm the only thing standing between everyone and Q&A, and this panel is too good not to let them get a grilling apart from me. So I will hand back to you, Mr. Lennox. Thank you.
Such humility, such humility. Okay, look, thanks. Let's take a wee moment now, guys. Thank you, particularly Mark Krzyzek, for making some really good observations. Before we take Mark's philosophical questions, I just wanted to kind of reiterate what this session title was. It's very much about using the PCN mechanic to actually help community pharmacy, particularly independent pharmacy, to actually make that journey with general practice. And I think at its absolute heart, that is it for me and most of us. It's about the relationship with general practice and the vehicle of PCN, if indeed the vehicle has wheels and is moving forward, you know, can you make it happen? So my first question around the panel would be, I'm hearing some people say they think the PCN model has actually probably stalled already. But yeah, on my patch and in other places I'm hearing it seems to be making quite good ground. So do you think PCNs are here to stay for the next period of time? Graham, you have skin in that particular game, being a dear clinical director yourself. What do you think? Are we living with them for the next several years?
I think the fact remains that there is no plan B, and NHS England have are invested in the PCN model, and increasingly funds are going to go via the networks rather than to GP practice. The analogy I give to local community pharmacists who can't quite grasp what it is, and when I go into the pharmacy and I'm swearing my head off because I've had a particularly bad meeting and they've tried to vote me out and all the rest of it, I'll go in there and I'll try and explain what's happened to GP practices. They've taken money from the practice, they've shoved it in a bowl in the middle of the table, and they've told 7 practices, you have to spend this together. Now imagine if we did that to your community pharmacies, took all 7 from that area and said, like, we're taking some money off you, there it is in the middle of the table, you have to play nicely and you have to spend this money together. And actually you can only spend it in the ways that we are talking about. So it's because we recognise, because PCNs were around trying to deal with GP shortages, trying to deal with nurse shortages, you're going to have to spend it in this way on these people. And if you can kind of see it from that perspective, GPs, I thought pharmacists squabbled a lot until I started doing this job. GPs, we've had to mute people before in meetings. So you'll be pleased to know it's not just pharmacists that argue, GPs do a lot of that as well. And the answer to your question, is there longevity in this? For as long as there's political will. And I don't see that political will wavering, and there is no other show in town. So the money is being invested. We've done projections that my small 60,000 PCN is going to be spending about £1.2 million by the end of this in year 5. That's a lot of money. Meanwhile, the CCGs are going to disappear and they're going to go up to larger regional levels. And so the PCN will be the delivery vehicle for local services. Of course, we could have an election and that could all change. You know, it's possible. But right now, the only show in town is PCNs. It's not perfect. But it's literally this last couple of weeks been 1 year. So let's be realistic. This is 1 year. We're still finding our way. We're still busy trying to hire people. So I've got some problems with the model. Of course I have. And what I don't like is the fact that the GPs think they own it. And the reason they think they own it is essentially they make up the boards. And we need to try very hard to ensure that at least the open sessions at the start of PCN meetings need to include our LPC leads. They need to include our district nurses, our dietitians, our physiotherapists, because they all have a stake. They are stakeholders in delivery locally. So whilst there is the current political will, I don't see there is another show in town. And that's kind of a strange way to answer your question. I think it's too early for delivery and for us to be able to point at outcomes at this stage. If the 3 specs that survived COVID and all the wrangles over the days, so that's SMR, enhanced health and care homes, and cancer screening, and pharmacy plays a key role in all of those things. If those 3 can be made to work, then we have a model that will be sustained. If the government continues to fund general practice through PCNs, the model will stay by necessity, is the answer. That's not really a very rousing, kind of positive way of framing it, but the fact remains, at the moment, it's the way that we will be delivering primary care with this current administration and their policy.
Graham, really pragmatically expressed. Thank you for that. I'm going to move on so we can draw in a couple of questions from audience and then beyond that. So, Mark Krishek, thank you. How has COVID-19 driven collaboration and integration within PCNs, between PCNs and pharmacy? Any practical examples of that, from our panel, please, as the spirit moves you.
So I think it's a really good question, and sorry, I cut across you, but I think there's some practical things that we were talking. Thanks. Practical things we talked about on the ground. I think the big one is ERD. I think there's been some stuff around that that's actually helped move the system faster, even though we've been talking about it for ages. And then there's the practicalities of the additional things about what to prescribe, what we can get, and how we work closer together. So I think in the PCNs that have got good leads and good relationships, I think it's driven more collaborative working and more collaborative talking. Like I said earlier, palliative care drugs came up specifically around what happens if, we get a massive COVID spike, but in Cornwall, we fortunately didn't. So I would say there's some practical examples that it has done. But I think there are still some issues with that, but I think it's thrown us together because we've had to.
Thanks, Nick. Lovejoy, please fire ahead.
Yeah, so I think the COVID-19 pandemic has driven collaboration and joint working, and the way that's happened in Greater Manchester is really through the CCG leads and our locality leads and even PCN clinical directors actually getting in touch with the LPC and actually asking for named community pharmacy leads in a specific area to be that point of contact. Now, out of that relationship, we were shared insights around end-of-life care patients and sort of a rapid deterioration of their health, and that then led to discussions, and we actually developed end-of-life rapid access to drugs and palliative care stock holding services across at least 7 of our localities as a result of those discussions. So we've actually had a very tangible joint working commission service effectively that's come out of it. Now, it wasn't commissioned by the PCN because they couldn't, but certainly the actual innovation and the ideas of what we need and how rapidly we need to access the drugs and how to set that up actually came from within the PCN. So I think that collaboration and the intensity of the pandemic has driven community pharmacy particularly to be invited to all the kind of planning programs. And I think now I've had a discussion with one of the Salford CCG actually, who've said, well, there's a PCN DES coming, and I don't know too much about them, but they've said that they feel that community pharmacy have a great opportunity here to help us achieve whatever that DES is going to be related as. Particularly what I've been told is in relation to care homes and providing support where there's gaps in provision. We don't know quite yet what that's going to look like because we're going to have a meeting in the next couple of weeks. But I think what I will say is, regardless of the political position, it is important that community pharmacy and GP practices work together better. I really love all the work that's been done around processes, and certainly that's not something I've mentioned, but we've got 9 Zoom calls with our GP leads, LMCs and clinical directors for each locality to actually iron out those very fundamental processes at the moment, because we recognise the fact that better communication, better processes, sending repeat orders via email, or all the kind of problems we have around MDS, the practical day-to-day issues that we have been resolved through these calls. But I think that's what set the foundation for us in order to have better conversations about innovating to provide services. So the next stage for us is going to be about seeing how community pharmacy can support the DES and whatever comes out of that. And so I think that the effort that our community pharmacies are putting in GF is paying off. And regardless of whether PCNs exist or not, we will need to work with general practice because it is the centre of primary care. And the funding primarily, in my view, will always, as a first port of call, go to GP practice first. So if we get that right and we get the relationships right, start integrating, improve our processes, build those relationships, we're in a much better position to be able to capitalise on whether it's DES or whether it's a local innovation. And that is going to require some effort, and it's not going to happen overnight. So I'm urging all community pharmacists, wherever they're sitting, to start speaking to the LPC and really start making an effort with the local GP practices they have, because that's what's going to drive the change. Thanks.
Beautifully expressed, Lovejoy. So a sort of a philosophical point here, and I might draw our other panelists in on this one. Collaboration is a word that's being used an awful lot at the minute, and collaboration is a two-way street. I just wanted to kind of get a feel from maybe Sanjeev and Neil. Do you think community pharmacy's up for collaboration? Because you know what, this isn't just about the GPs and the PCNs going, we want to collaborate. Pharmacy has to want to. Is all of pharmacy up for that collaborative mindset? Neil, what's your experience and what's your belief? And then Sanjeev.
Don't kick me for this when I say it. I think if I'm really honest, some really good experiences that I've had have often been with the independent pharmacies, and that's been really positive, and that's worked well. I think the multiples, that's more interesting, but it's possible, but it's varied. That's been my experience. I think we're all incredibly busy people. COVID's not helped that. I think collaboration is a often used word. I think it's variable. The problem with collaboration, there isn't a problem with it, but the challenge of it is the time that we actually have to do it, and it takes time often with no immediate kind of production of a product that feels like it was worth it. It takes time to work through some of that. I think we've got to collaborate. There's no other way to go. The reality is we're all drowning in workload. We need to think about how we reform that and do it in different ways. Working together will give us a greater chance. And I think I saw in the chat, I think it was Nick, this concept about sub-commissioning and some of those approaches. That is really interesting, because it feels sometimes that there might be ways that we could use funding to unlock some of these pathways or closer working, but we can't within the primary care networks at the moment, and that makes it more challenging. But yeah, I mean, I think we could do much more. My experience with community pharmacy is it can be mixed, and actually it requires time to be given up, and I think that's a problem for us all. And culturally, we often feel the need to just get on and do what we're doing and run a little bit faster than we do to step off and think, actually, we've got to do it in a different way, because this is not sustainable. So, yeah, I think it's a mixed picture.
Thanks, mate. I mean, just to reiterate your point, I suspect at the minute that independent pharmacy, because it is absolutely local, it's absolutely self-empowered and agile, probably has the greater will to go deeper, faster locally. That's my experience as well on my own patch. Sanjeev, anything to observe on that in terms of the will to collaborate?
Yeah, definitely. I think there's a definite appetite to collaborate and to enhance on the service that are provided. I mean, with COVID, that's demonstrated where so many locally commissioned services were kind of closed doors from a lot of the providers overnight. Community pharmacies stepped up. So especially in our area, sexual health clinics, everything was referred to ourselves. We were happy to take that on, and we were almost the only providers of the service at the time that could help patients out with that. Smoking clinics was the same. Substance misuse services, we had to engage with the local commissioners to keep them abreast of monitoring clients. Really, has there been any deterioration in clients, and monitoring their health and care as well. So there's definitely an appetite to do it. I think what's just been said about the workload is one factor which obviously sometimes can be an inhibiting factor. That being said, I think that the whole supply function of medication is what puts community pharmacy in such a unique position as an enabler to provide services, because it's the supply function that enables us to see patients on a monthly basis and actually almost opportunistically provide healthcare advice and different services. So there's definitely an appetite, but it's just making sure that we've got the correct model and the funding to be able to provide those services, and also upskilling all of our staff. We've got the healthcare teams to provide these, but there's got to be some level of upskilling and training, and then that integration with the other providers to cross-refer across those different healthcare providers.
Sanjeev, thank you. Just to take a wee moment then and recognise the lovely chat that's going on, and thank you, Graham and Nick and Andrew for reaching out and exchanging to each other. It sort of teased my next question up quite nicely. So, who are the midwives of this birth of collaboration then? So we talked a little bit about the LPCs a short while ago and their role in it, and Lovejoy from Manchester shared the really practical stuff. But who else do you think can enable or should enable what needs to happen at the interface between community pharmacy, general practice, and the PCN? And it's as much about the human interface as it is the process interface. Any practical or philosophical points to share about, you know, who else can help this stuff happen, please? Or not?
Yeah, sorry, I was going to just add a quick point there. I'll keep it brief, but I think we do need to seek help from our executive leads, NHS England, NHS Improvement, or as in a devolved structure, the Greater Manchester Health and Social Care Partnership, because individual PCNs are very busy, community pharmacy is very busy. So we've leveraged the contacts that we have to use that as a bridging to actually bring people together, to have that communication, start those discussions. And without their sort of oversight and blessing, I suppose, I think the challenge for me from where I'm sitting is it's extremely challenging to manage 58 PCNs who are actually in completely different place, completely different priorities, don't really understand what they're trying to do, and we don't actually understand how willing they are to collaborate. So I think we do need to get higher level executive, whether it's NHS England Improvement or the partnership as in Greater Manchester, to be involved and actually to help us to drive that collaboration. The LMCs also have a very important role, and I think them working in collaboration and with the LPCs and also supporting and developing the vision for how PCN and local collaboration is going to work is going to be extremely key. It's not just going to happen individually. There needs to be some sort of oversight and some kind of looking after and supporting that process, so that I call them the toddlers, so that we support them to a point, then we can release them, and that they're confident to be able to go out and have those relationships and develop integrated working models by themselves.
Yeah, spot on. And you know, as well as proudly working for the NPA, I support the profession across Somerset, and what Lovejoy shared there is exactly my experience. I have a very strong relationship now with the CCG and the primary care team, and you know, they've actually invested in the 102 contractors across Somerset. They provided us funding so that we can, certainly pre-COVID, release our primary care network leads. I'm lucky in that it's 13 leads across 13 PCNs. So for a small LPC, it's a manageable burden, you know, 13 initiating that. But I think LPC system and the thing that glues the PCNs back together, maybe across a larger health economy, you know, we need to be leveraging them. I would also point the finger though at the national bodies and say, what are we doing nationally to enable this? You know, there was the PQS around PCNs, but that was just switch money, wasn't it? That was just to get people's attention. That hasn't really so far changed the dynamic. I'm interested in finding out what's going to happen next. What does PQS do? What does our national contract do? Are we going to be doing stuff contractually that supports Graham as a clinical director across the DES? So maybe let's take a moment now and have a wee kick around at you know, what we think would create the better landscape so that we more work together. Graham, in terms of contract alignment, if we don't get the contracts right and we don't get the kind of the money right, I suppose there's always that divide between us. Can you see a time when our national contracts are beautifully aligned and kind of self-fulfilling, supporting?
I think they need to be. I think that's clear for everybody to see. To my mind, there are aspects of my local community that need attention. It can be smoking cessation, we've mentioned that. It can be asthma, it can be anxiety, it can be immunisation. There's 4 that are a really big deal in my PCN, and I look at the community pharmacists and think that they really are placed. There are ways, so within and it's being suspended, but the IIF, the Investment and Impact Fund monies, are there for really mundane things. So switching to dry powder inhalers, for example, for immunisations and so on. So there are some monies there, and if PCNs are struggling to deliver that, there is potential then for pharmacy to be involved and help with that. If we can, as you say, align contracts to reward community pharmacy to to deliver on those services. Now, if local needs are identified, shouldn't we allow some measure of, within the kind of accountable care organisations, SDP, call them what we will, some measure of localised contractual adjustments to recognise we have a low level of immunisation, or we have a serious problem with smoking related illnesses, and let's commission together then both the practices and the pharmacies to deliver services towards that. And I think that will start to happen as we struggle year 2, year 3 to meet the impact fund requirements, and actually look broader to say, actually, if we can't get our own people in, let's use other people's. Let's be more flexible with our budgets. And I think actually, let's hope the commissioning, if you like, the contractual arrangements, essentially force people to do that, to bring people together in that way. And I think that would be a very constructive way forward. I have some ideas around how we motivate and how we make those LPC PCN leads as effective as they can be. And to my mind, it is. People tonight have started to share examples of best practice that are working in their localities. So why not have a repository potentially shared between the NPA, the PCPA, and any other interested organisation, where people can draw out business plans that have worked elsewhere and have people who can advocate for that particular way of working, so that they can go on to their local PCNs with workable solutions to local problems and pick from a menu. And I know that BSNC for a long time have posted deep data on enhanced schemes, locally enhanced schemes. So why not do the same in PCNs? Why not extend that so that our LPC leads can go with meaningful solutions to problems that will work for their basis? So the LPC leads need training on accessing these inequalities and these unwanted variations, if you like, between similar areas. Why is smoking so much worse in one area? Why is drug misuse worse in one area? So that they can adapt and mould and pick and choose between offerings that have worked elsewhere, so that their clinical directors can see what they can do, and they've worked. And we've got to take time to build that up. And I couldn't advocate more for bringing people together. In the end, we can't bring buildings together. We shouldn't even try. If we can bring people together with workable solutions, then we might start to have local level engagement that will bear fruit in other ways.
I'm so with you in spirit, and I know we've had some dialogue between the NPA and PCPA recently that's been really positive and constructive. I can see us maybe acting as a joint catalyst for change on that. Nick, did you want to come in, sir?
Yeah, thank you, Michael. So I think to your original question, which is around how national organisations help support this, I think this is actually really quite difficult, because actually national organisations supporting local is classically quite hard. But however, I do, yeah. Hadn't the right review. Did I say that out loud? But I think for me, actually, there's some stuff here about, what the NPA should be doing and is doing is talking to the BMA about how we work together. Darren's put some great comments there about, flu and working together. I mean, that's the level that the national should be working at. Look at the community pharmacy, GP referrals, community pharmacy consultation service. If you get that right as a partner in GP practice, I make more.
We might be losing you a little bit, Nick.
On seats. In a community pharmacy, I get more money if I'm doing a really basic example of where contracting alignment does that. Am I back?
You're back and strong.
I'm back and strong. So basically what I was saying is national should be supporting local, national should be supporting contractual alignment. The problem with local is, which is really important where the innovation happens, it's how you share that repository up and down, to Graham's point. If my connection's a bit iffy, then I'll stop. Thanks.
Thank you, Nick. Point well made. So look, we had kind of lined up this to potentially kind of run up to an end point of 9 p.m. But I think we've shared an awful lot of really sensible stuff here, and this is going to be kind of edited and shared out as a link. I'm just going to whiz around the panel one more time, and then I'll do my wrap up if that's okay. Sanjeev, is there anything else that you would like to add specifically as an observation based on what we've kicked around tonight, please?
I think the variability actually in everyone's experience of their personal experience of how PCNs have worked effectively or not around the country is quite interesting. So it shows that it really can work if it's executed well. So it's a lot of it. I think we need to take learnings from the areas where it has worked and where the engagement has taken place, and apply that, those learnings across the board. And it shows that if that happens, it can be a fantastic structure really, to where these professionals, where we can all work together to have a conjoined kind of health outcome. So I think it's really positive to see that if we take it in the right direction, it can work really effectively in the long term and cement community pharmacy's place in the whole healthcare agenda. So definitely, yeah.
Thanks, Sanjeev. And to reiterate Graham's point, if not the PCA and us in the NPA trying to do something, then who? So we will explore that further, I'm sure. Neil, may I draw you in just for any final observations, please, to let you get off and get a well-deserved cup of tea as well?
I think I'd just say, I think there still needs to be some national drivers. I think that's really important. I think at a very practical level, I still think about, PCNs making sure that they connect with their local LPC colleagues, making sure that, trying to find some common pieces of work to work on would be my observation, and keep going. It requires energy and effort, and it doesn't happen on its own. So that would be my kind of bit of a thought for the day.
Yeah, keep on keeping on. Thank you. Lovejoy, final thought from yourself, please.
Yeah, it's been really great to listen to everybody's, and thank you for all your questions. I think the final conclusion that I'll say is I think there's one level where we can influence locally, which is definitely around improving processes, communication, engagement. But I think we've got some work to do. And Michael and Graham, I'm looking at both of you as a start, that we do need to have something in place which is a structured program that we can leverage to drive this. So, for example, whether it's a joint vaccination target or a jointly, led program that's actually been specified for us to deliver, that is going to be absolutely crucial. Otherwise, we're just going to have pockets of good practice, and it's not going to be at scale. And that's what my concern is. I see 58 PCNs in Greater Manchester. And the third one is that I think we need to do more to educate our community pharmacists to really make an effort to engage with their LPC, engage with their PCN lead, so that we can actually at least set the foundation for communications engagement to build something on. So I think those national levers, again, we do need that. And I think it's probably more required than ever for us to actually do some influencing to make that happen.
Thank you. Well said. And I know your role within the PCPA as the person that's going to mold what happens with community pharmacy is going to be central to this, Lovejoy. So thank you for what you're going to do. Graham, may I come to yourself just for a final obs, please?
Okay, so what I've said is that PCNs are about workforce, and I think we need to think bigger. And I can foresee independent community, well, not just independent, but community pharmacy is a place to deliver those services if we can get workforce. So let's aim high. Let's go for a professional in all of our community pharmacists, funded by the ARRS, delivering services for patients, utilising joint IT, and funded via the PCN. Now, if you imagine you have a half-time pharmacist that comes into your pharmacy every afternoon and deals with those issues, not just flu, not just hypertension, but also the SMRs, goes and visits the local community, the local care home that you provide medication for, funded by the ARRS via the PCN. If we can make that happen on a broad scale, so that healthcare professionals are based in the community pharmacies delivering the services that we know we can deliver, then we've started to crack it, and that can be made to happen. And I'm determined that we try and make that happen and deliver the services from the pharmacies, not just from the PCN. Doctors don't own this. This is a network. It's supposed to be community providers. And independent community pharmacies, pharmacies in general, are exactly that. Often open longer hours, certainly more accessible. So we have some key unique selling points that we need to bring to the table. And I guess our job, if we're going to call ourselves leaders, if we're going to call ourselves representative bodies, is to actually facilitate that. So individuals, that 24-year-old who's put themselves forward and is bold enough to go and talk to the GP, which can't have been an easy thing. We need to give them the tools and the examples that they can go and make effective change in their localities. And I think that, for me, if we can achieve that, we'll have achieved a great deal. And it is not necessarily about national contracts. It's about local individuals utilising tools and persuading people of the right way to work.
Fantastic, Graham. Thank you. Nick, as chair of the Policy and Practice Group on NPA, as well as a practitioner across the interface, what would you leave us with as a thought, please?
Well, I think all the speakers tonight have been absolutely fantastic. I want to thank everyone for their time. For me, it's around how the primary care networks can be the place for service alignment and for best delivery of the patient. I like the idea of not moving the people into the buildings, but moving the system around them. And actually, from a national point of view, somehow we need to give community pharmacists or pharmacists in that role the space to grow and develop. So for me, the community pharmacist PCN leads need to have the space and the time to be nurtured and grown in the right way. So again, I would echo what Graham's saying. It's about growing the people locally and sharing the best practice. And we need to be supporting that with national drivers at the NPA.
Thanks, Nick, and I'll certainly take that on the chin, as this is my area of support for the NPA. So look, I really enjoyed that. Great panelists, great dialogue, great issues that we were kicking around. Thanks to you for participants for witnessing this and being part of it. We have recorded this. We will package it up and put it out. As to our colleague Mark's point earlier on, you know, it's a late Thursday night. There's a lot on, and we didn't promote this heavily for a long period of time. But we will now. We will take what we've made tonight together, and we will package it up and promote it out there. So again, look, thank you to my colleagues Ashley and Kat for facilitating and enabling this. Most importantly, thank you to our members and other pharmacy colleagues for turning up. And look out for the link. And when the link lands, please share it across your networks as well. Thanks again, and good night.